Mhm.
Okay, I am joined by Dr. Tiffany Woodus, an obstetric gynecologist based in Dallas, Texas. Dr. Woodus received her medical training at the University of Arkansas for Medical Sciences in Little Rock in 2006. Then she underwent her residency at UT Southwestern Medical Center and graduated in 2010. She's currently in the process of opening her own practice in Cedar Park, Texas, and she's also a mom and wife. So welcome, Dr. Woodus.
Thank you very much. I appreciate you.
All right. So Dr. Woodus and I met on the Instagram, and I started following her in conversations that she has around fibroids, periods, having babies. And it's been exciting learning from you and learning that there's such a big community out there, especially of Black women physicians and nurses that are really trying to educate the public and shine a light on, medical disparities, and also give education opportunities to moms who might not have the source of information that other people do have. So welcome.
Thank you very much. Yes, it's been an incredible journey. I too have been very pleased by the support and the feedback that I found among Black birth workers online, and the camaraderie and the spirit towards educating and improving outcomes for Black women's healthcare has been phenomenal.
All right. Tell us a little bit about your family.
Well, I am a mom of 3-year-old twins and a soon-to-be first grader, and they keep me extremely busy. Also a wife. And so it's been quite a journey in terms of figuring out how to balance, how to be available, and how to show up as my best self in both my professional space and my mommy and wife space. It's definitely something that's still evolving and definitely something I'm still figuring out and growing into. But it's been super helpful to have a supportive partner who's been with me, long before this journey started, understands it and supports me 100%. So that's been probably the most critical piece of balance that I have found in my life.
So yeah, the common theme that I keep hearing from moms in medical professions is balance. We spend so much of our time taking care of other people and fixing other people's problems. And it's hard to navigate that. Like, how do I still take care of my patients and still give my best to my family? And a lot of it too has to do with support. And I feel like especially spouses don't get enough credit. And sometimes they don't do a lot of work, but it's just knowing that you have that person that's looking out for you, that understands why you chose this profession, and that you might not always be available, but they're willing to step in and step up. So it's great. I feel like, the conversation around balancing motherhood, there's got to be some honesty about balance.
Okay. Absolutely.
Yeah.
And I just had to finally make a decision to prioritize. I mean, I just had to decide that this is how I can be available to my patients, and this is how I need to be available to my family, because there came a point where I felt like my family was getting scraps. They were getting leftovers. I was giving everything to my job, my profession, my patients, and then my family was just kind of, it was kind of, oh, well, might as well, in terms of what I was able to offer them and how available I was to them. So I just really had to sit down and decide what I wanted my life to look like, pull back in some areas, and make a decision to be okay with that.
Absolutely. And, part of it too is like, we've been programmed to be so good at what we do. And then when you see that one side of your life is suffering, that decision is difficult, deciding, okay, you know what, I'm going to cut back on this so I can be fully present for my kids and I can be fully present for my spouse. And I believe that that vulnerability is so important for moms to give themselves grace. Like, listen, you can't be the end all be all in the hospital and at home. And, as unfair as it sounds, because I don't think this is a conversation that happens, especially with dads, it's kind of just how we're, that's the role we play in society. And it does sound unfair, but honestly, like when I look back and I see how far the 2 years with my daughter went, it's not time that I'm going to get back. Right. And so does it mean scaling back professionally, not stepping up for roles that I may have stepped up to before I had a kid? And it's almost like you have to be like, am I giving up on me? And honestly, you're not. You're giving into your kids, right? And your family. And that's okay.
I had to redefine what I considered success. You know, at the end of the day, is it going to matter that I missed that delivery? Is it going to matter that I, you know, delegated that responsibility at the hospital? Or is it going to matter that, you know, my daughter doesn't remember me being present during her formative years? You know, what is really going to matter?
What is important?
Exactly. What is important?
Yeah. And truly just giving yourself permission to let go of the expectations that you had of yourself, right? And giving yourself permission to be like, you know what, this is plan B and this is okay. And structuring your work life to suit your family life and not the other way around, you know, not structuring your family life to fit into your job. And I think a lot of employers, you know, need to acknowledge this challenge with moms. Like, we do want to give our best. We do want to be present, but you know what? I'm not going to be present if I'm not present at home.
Right.
And that's okay.
Right.
And please give me permission to be that person. And if that means stepping into another job role or leaving a certain position, you know, I see moms who are like, I never thought I would go part-time, but you know what? Here I am and I'm happy and I'm doing it and my kids are thriving.
Absolutely.
And, you know, I always say, like, I took an extended maternity leave and I always said, you know, I'll make that money some other time. You know, my kid's not going to be 3 months old forever. And, you know, I don't feel like it impacted my finances that much, but.
Absolutely. It was one of the main reasons that I made the transition from academic medicine into hospitalist medicine, because it essentially gave me a part-time schedule. It gave me a set of expectations where, okay, these 24 hours, 2 to 3 times a week, I'm in the hospital. This is me. This is what I'm doing. I'm not leaving. I'm 100% committed to this. And then when I'm at home, I get to be at home. I'm not on call, you know, I don't have an inbox that's filling up. I don't have prescriptions to fill and phone calls to return. And so I can be, you know, I can be room mom and I can be present for the birthday parties and, you know, actually participate in these things that matter to my children, these things that matter to my husband.
Absolutely.
Yeah.
All right. So we're going to hop on to talking about periods and period pain. And I actually was reading some posts on a mom group I'm on, and I was like, oh my God, this is a perfect conversation. Because this mom was like, around the first day of my period or right before I get my period, I have horrendous abdominal pain. It goes all the way to my knees and it hurts the most and it's so bad and it makes me nauseated. And I was like, oh, that sounds awful. Like, you always expect that every, 24 to 28 days. So tell us a little bit about, and I'm going to probably butcher this name because I can't say it correctly, dysmenorrhea. Is that correct?
That's great. Dysmenorrhea.
Okay.
Yes.
Tell us a little bit about that. And I know there's 2 primary versus secondary. So can you talk to us a little bit about that?
Yes. So dysmenorrhea is just pain with your menstrual cycle. It is a natural process that typically happens when a woman can start menstruating. So primary dysmenorrhea essentially starts when you start potentially having your periods. It's the most common complaint that we see associated with menstrual cycles. Somewhere between 1 and 2 women will have some sort of pain or discomfort with their menstrual cycle at least 1 or 2 days out of the cycle. So primary dysmenorrhea has to do with pain associated with the natural process of having a menstrual cycle. When we look at it, research indicates that it has to do with the buildup of hormones, so primarily prostaglandin, which is one of the hormones that's made in the lining of the uterus. And so women will complain of having discomfort like menstrual cramps 1 or 2 days prior to the onset of their bleeding. And so that's when the synthesis of prostaglandins are the highest. And then as you go throughout the cycle, they decline. So as that lining sheds where this hormone is made, then your symptoms typically decline. This type of dysmenorrhea, primary dysmenorrhea, tends to be something that gets better as we get older. It can get better after we have babies as well. And it tends to be more isolated to the period. So a predictable cyclic pain that kind of starts with your period and stops when your period ends. So that's what sets it apart from secondary dysmenorrhea. Secondary dysmenorrhea has more to do with an abnormality of the menstrual of the menstrual tract. And so it can be associated with disorders, if you will, of the menstrual tract. For example, it tends to start later in a woman's menstrual life cycle. And it can be associated with conditions or abnormalities like endometriosis, which is where the tissue that would normally line the inside of the uterus is found outside of the cavity in places that it's not supposed to be. And it functions and behaves just like it would if it were in the right place. So it would remain, Yeah, it remains hormonally responsive. So when the hormones from your brain trigger your ovaries to start this cycle, wherever those implants are, it responds and reacts as if it would inside the uterine lining. So you can have a lot of pain and discomfort associated with that process, depending on where the tissue is. If it's near your bladder, you can have urinary issues. If it's near your bowel issues. It could cause pain with intercourse. It could also cause adhesive disease, which is where the tissue is sticky and stuck to where it should not be. That scar tissue and those adhesions can definitely lead to some other complications down the road. Other things that can cause secondary dysmenorrhea are adenomyosis, which is a very similar concept to endometriosis. So instead of the tissue being outside of the cavity, it actually gets trapped within the walls of the uterus. So there's 3 layers to the uterus: that inside cavity where the menstrual tissue forms that you shed each month. Outside of that is a muscle layer of the uterus, and then there's an outer layer of the uterus as well. And so this adenomyosis is a process where the tissue that lines the cavity is trapped in the muscle layer. And it makes the uterus look bigger, boggy, almost, and it causes pain and discomfort as well. And then you could have conditions like fibroids that could be a cause for secondary dysmenorrhea. And a fibroid is an overgrowth of the tissue that normally lines that muscle layer of the uterus. And so all of those things could be an issue. This type of pain may not be just isolated to the menstrual cycle. You could have it starting prior to your period. It might get worse with your period. It even persists after your period. So it's not just isolated to that 5 to 7 days that you might consider your normal menstrual period. It does not necessarily get better as we get older either.
Wow. So basically these, like, I guess the normal,
I'm sorry, I didn't hear you.
the abnormal locations of the tissue can be anywhere.
Yes, it can. It can. It can. So near the bowel, the bladder, you can have it in very strange places. I've seen it on the skin, believe it or not.
Oh, wow.
Yeah, it's been it can be very, very interesting.
And so as far as primary, like, what are some things that you can do at home to kind of ease the pain and kind of, you know, handle it on your own at home?
That's a good question. And so one of the things that we try to encourage women to start with is basically interventions that are the least invasive and have to do with lifestyle modifications, conservative management, if you will. So if you can track your cycle and anticipate, assuming you have regular periods, when your period is going to come, preparing for that time can be super helpful. So since we know that it has to do with the buildup of hormones, the prostaglandins, what we can do is encourage women to consider taking anti-inflammatory medicines like ibuprofen or Motrin or naproxen, because that decreases the production or buildup of that hormone. And it tends to be the most helpful if you start taking it a few days before your menstrual period and continue it during those first few days, when then that hormone level would start to naturally decline anyway. And then we find that exercising consistently can also help decrease some of the symptoms you might experience. Doing things like making sure that you're staying well hydrated, getting plenty of rest, using warm baths or warm compresses can also be helpful as well. So those are some of the lifestyle modifications that women have shown to help with this cycle.
Well, diet and exercise is always the thing, right?
Yeah,
Are there any dietary changes that you recommend in that time frame, like foods to avoid or foods that you probably should eat a little bit of more when you're experiencing symptoms?
In terms of food, we have seen sometimes that foods that are less prone to be associated with inflammation can be helpful because the buildup of hormones creates an inflammatory kind of cascade, if you will. And so sometimes avoiding dairy, sometimes dairy products can be associated with increased levels of inflammation. There are certain vitamins sometimes, like vitamin D, vitamin A, that have been associated with decreasing inflammation. So sometimes paying attention to those types of foods can be helpful.
And as far as medical management, what kind of medications would you, I guess, prescribe to a patient, especially with a secondary dysmenorrhea? What would you have them on as far as regimen?
Mm-hmm. If it's a matter of pain control, sometimes we can start with the anti-inflammatory medicines, like we mentioned. Other times we could consider hormonal regulation to help kind of hijack the cycle and make it behave. And so a lot of times if we can take over the control of the hormones, we can decrease the effects that a woman is experiencing. So sometimes things as simple as birth control pills or some form of that, whether it's pills or a patch ring, or even IUDs, or Depo-Provera, the injectable hormones, can help in terms of hijacking the cycle and controlling the symptoms that may be associated with it. So those are things that we tackle usually as initial recommendations.
And what kind of invasive procedures, I guess, do patients with dysmenorrhea, what are the options available for them?
It depends on our ability to identify the source. And so if we think that it is because of endometriosis, and you're thinking about invasive procedures, sometimes laparoscopy, minimally invasive procedure where a camera is placed to look and examine the pelvis and the abdomen. If you see evidence of endometriosis, and it's safe to proceed with destroying or removing those areas, a lot of times that can give women relief. Or if the endometriosis is such that it has formed a cyst, sometimes that can be a source of pain and needs to be removed. It's called an endometrioma. If the endometriosis has led to scar tissue, trying to put the anatomy back where it should be and take down those adhesions can be a source of relief for some women. If it is an issue related to fibroids, then the minimally invasive surgical procedures that we would consider are things like uterine artery embolization, which is a radiology procedure. It's where the radiologist maps out where the uterine arteries are, and they actually place a substance there to block the blood flow through that artery. And then it thereby decreases the blood flow to that fibroid, or decreases its source of nutrition, if you will, and causes it to shrink and regress. And then there are other procedures such as Accessa, which is a procedure, it's an ultrasound guided procedure done in the operating room where you map out where the fibroid is, and then you actually use an instrument that goes through the abdomen directly into the fibroid, and it uses radio frequency ablation to actually destroy that tissue and cause it to shrink down and digress. In both of those, the uterine artery embolization and the Accessa procedure decrease significantly the symptoms that can be associated with fibroids. There's a newer procedure similar to Accessa that has, instead of that abdominal approach, it has a cervical approach. And so ultrasound guidance is used, and you go in through that approach to do the same thing, which is to destroy the fibroid. And then outside of that, you get into myomectomies, which is where you surgically remove the fibroid. And that can be done minimally invasively, via laparoscopy or hysteroscopy, which instead of the camera being placed in the abdomen is placed down through the pelvis, through the cervix. Just depends on where the location of the fibroid is. And sometimes it's done with an open procedure where an incision, it could be a small incision, but like a C-section incision is made to remove the fibroid.
Gotcha. It's also interesting because, like, just going through social media and, like, when people talk about period pain, one very common theme, especially in Black women, is that, you know, they go see their doctor and they complain about these symptoms, and sometimes they get the treatment they need, and then sometimes they say they feel like they were being treated as drug seeking. And so I feel like that does impact, like, seeking care for the condition. And how do you advocate for your patients in order to ensure that their voice is being heard? And what would you recommend patients to do in order to be better advocates for themselves?
That's a great question. And unfortunately, it's something that I hear far too often. I think we have to really do a good job educating ourselves about our condition so that we are equipped to know what to ask and understand what we are hearing. And so if I don't know anything about what it is that you're telling me or what you're presenting me with, I'm at mercy in terms of understanding my body, understanding my condition. I'm at the mercy of what you choose to tell me. And unfortunately, too often, what we look like and people's preconceived notions of us dictates what they choose to tell us. You know, how much patience they have for us, how much consideration they have for us. all of those things. And so I think that when you hear a diagnosis, if someone is considering things, you need to take it upon yourself to then go home. First of all, take notes, write it down, because when you're in a somewhat intimidating situation, you're hearing information you did not expect to hear. This is not what I came to the doctor for. And now I'm being told that I've got something potentially that I've never heard of. Write it down, because you may not remember it. You may not be thinking rationally because of anxiety or being upset, or it's a stressful situation. Write it down and then go look it up, and make sure that what you're looking up is reliable information, that you're getting information from tried and true proven sources, and then bring those questions back to the doctor with you. Bring a support person with you too, because all of us need someone who can advocate on our behalf, because when we're in emotional situations, things fly out of our heads all the time. And so having it written down and having someone to remind you and trigger you, remember you had this concern too, or remember you wanted to talk to them about this too, can be super helpful. Because you never know how the conversation is going to go, and it could just get you off track, and you need that support. So those are some of the big things that I tell people to do. And then I always encourage folks to make sure that their physician or their provider is asking for their opinion and giving them options. Even if I have in my mind what I think a patient needs to do, I'm still going to tell them what the options are, and then tell them what the pluses and minuses are in each of those things. These are the 5 treatments that I think you could consider for the treatment of this condition. This is why I like this one. This is why I don't like this one. This is why, I put this one on the list. But you need a buffet of options, and then you need to have the risk and benefits, the alternatives, the indications laid out for you so that you can make the best decision for you, not just someone telling you what they think you need to do with your body. So I think those are some of the biggest things.
I actually started a thing where, like, if I have a doctor's appointment on my calendar, I'll put it in the notes section, like all the things I'm going to ask, because you go there and you're like all flustered, and then you realize, I forgot to ask about this. And so, like, I have a OB appointment, and I totally forgot. I went to the OB, and she reminded me of something, and it said I have a G6PD deficiency. And I realized, like, I found this out when I was pregnant, but I still haven't told my PCP about it. And so for my PCP appointment, I wrote, please remind doctor, about this, because although, like, I've never really had symptoms, like, she was just concerned, like, if I was put on medication for bladder infection, like, just to make sure my PCP was aware. And so it's also, like, even with telemedicine, I feel like now patients, you're at home, and it's a little more comfortable of an environment. Write that stuff down so that when you have that televisit, like, you can be like, oh yeah, and I remembered this, and I didn't remember to ask you about it.
Right. I would also say it's important to consider seeking another opinion, especially when we are getting into situations where we're thinking about something serious like surgery, which it doesn't matter how minor the procedure is, surgery is always serious. Anesthesia is always a serious ordeal, and so get a second opinion, get a third opinion if you need to, so that you can really look at all perspectives, all aspects, to make sure that you're making the best decision for you. If you feel like, your physician doesn't have good bedside manners, they're rushing you through the situation, we need to give people grace. Everybody, every situation is not going to be ideal necessarily. We all have bad days, but if this is a recurrent theme, if someone is not meeting you where you are, not explaining things to where you're satisfied, not willing to answer your questions, engage you in the conversation, really consider your opinions, and that is not where you should be.
Absolutely. And one thing I think about too is, like, for me, anesthesia is easy unless it's my family or me getting it, right? And same thing for the physician, surgery is an easy option until it's your family. Exactly. And so always, be considerate of that, and just ask all the questions, and be an informed patient. So my next question is related to premenstrual syndrome, aka PMS. And what is the difference between just regular PMS and premenstrual dysphoric disorder?
Good question. So premenstrual syndrome has to do with the physical and emotional changes that a woman can experience related to the fluctuation of hormones around her period. Physical symptoms might be breast tenderness, bloating, water retention, swelling, and then emotional symptoms might be irritability, crying, fatigue, depression, anxiety. And so we go from PMS, premenstrual syndrome, to PMDD when these symptoms are significantly disruptive. When you have tried behavior modifications, when you have tried modifying your environment and you have found that simple conservative management is not helping you, and these symptoms, these emotions are becoming a hindrance to your ability to function. They're interfering with your interpersonal relationships. They're interfering with your ability to work and to function. That's when it becomes premenstrual dysphoric disorder. So it is rare PMDD, and it is an extreme, it's an extreme example of PMS.
Gotcha. And what are like some management modalities for PMDD? Like, are there medications that patients get on?
A lot of the medications are the same as what we would typically use for the treatment of depression and anxiety. Sometimes birth control pills can be used because we can hijack those hormones and make them behave. And kind of temper, if you will, your response to these fluctuations in hormones by controlling them. But oftentimes you'll get into medications that are typically used for depression and anxiety. There have been some roles for behavior modifications in terms of controlling your environment, or even non-traditional treatments like acupuncture as well.
I'm a big proponent of acupuncture, actually. I actually went to an acupuncturist when I used to struggle with insomnia, and he helped me out. And I did it also for my, my first trimester and my last trimester, I had really bad reflux, vomiting, and it helped.
Gotcha. I've seen a lot more research in this area too, in terms of dietary changes to help control PMS or PMDD symptoms. There's some literature that supports having a diet rich in complex carbohydrates, decreasing the fats, the sugars in your diet, increasing your protein and water intake as well has been helpful. Magnesium sometimes is cited as helpful for this particular disorder. Sometimes vitamin E has been helpful. So there's a lot more, it sounds like, research around dietary interventions for this type of concern.
Okay. My next question is related to pelvic inflammatory disease, and basically, like, what are the symptoms and how do you identify that that's what it is, and how do you treat it?
Pelvic inflammatory disease is an ascending infection of the reproductive tract. And so it's an infection typically most commonly caused by gonorrhea, chlamydia, so sexually transmitted infections. I say that, but you can also have pelvic inflammatory disease because of bacterial vaginosis, which is an overgrowth of the normal bacteria that's found in the reproductive tract. And basically, this infection is able to go from the lower genital tract, so vagina, and access the upper genital tract, so through the cervix, and then affect the uterus, tubes, and ovaries, and then the pelvis as well. And so that's what it is. Symptoms that can be associated with it. Sometimes women are walking around and have no symptoms. You can be asymptomatic with pelvic inflammatory disease. Sometimes it could just be a dull ache or discomfort that you have in your pelvis. And then sometimes you can have extreme pelvic pain, fever, nausea, vomiting, and irregular bleeding as well.
Okay, and how do you treat it?
Yes, and so it's treated typically by antibiotics. The route of the antibiotics just depends on how symptomatic a patient is. And so if you are healthy and you're able to tolerate food and you don't have an abscess or a collection of infection in your pelvis because of this infection, then sometimes just oral antibiotics can be used as treatment. Other times, if you are more significantly affected, you might need to be in the hospital and receive IV or intravenous antibiotics for treatment.
Okay, so I'm going to switch gears just a little bit. I have some questions about birth control options.
Okay.
I guess one question that for myself, I had a questionable clotting disorder. They couldn't figure it out. And so my hematologist said, if you wanted IUD, you could not have hormonal IUD. And so I never looked into the others. I just went with a copper IUD as my option. What is, what would you recommend one over the other between a copper IUD and a hormonal IUD?
So you bring up a good point. It definitely is individualized for each specific patient. My personal preference are the hormonal IUDs because I love what they do for most women for their menstrual cycle. So we're talking about the progesterone Iuds, which is Mirena, Kyleena, Liletta, Skyla. And then the Paragard, which is the non-hormonal or copper IUD, is the only other IUD outside of that category. And so the progesterone IUDs, the whole class, what it does is it thins the lining, that lining that we talked about in terms of where the hormone production comes from. When we were talking about dysmenorrhea, it thins and sheds that lining. And so for most women, it significantly decreases the amount of blood loss you have with your cycle. And so we kind of get into this singular mind frame when we talk about birth control, but as practicing physicians, we use it for so much more. And so we can use it to control a lot of the unfavorable symptoms you can have with your menstrual cycle, excessive bleeding, cramping, heavy periods, all of that. And so that's why I tend to like the hormonal IUD better. But for women with certain conditions, it might not be the best choice. When we talk about increased risk for blood clotting, we typically are talking about an estrogen effect. And it is important to note that the IUDs do not have estrogen in them. However, if there is someone who has recently had a clot, or is an ongoing issue, not yet under control, then in that situation, you still might not want to consider a hormonal anything for them. So that might have been the thought process behind why you were directed in the direction of the non-hormonal IUD.
Yeah, so my situation actually was my OB was like, she was okay with both, and my hematologist was like, it's a hormone. And I did have a PE when I was on birth control, a hormone, so she was like, I don't want any hormones for you. And my OB was like, whatever she decides, we have to go with her, because if we do the contrary and you get another
Yeah, absolutely. It's teamwork makes the dream work, you need that team. You need those minds working together because they may see a perspective that I don't, and vice versa. And so we really have to work together and inform each other to make the best decision. And the patient is a part of the team, you're a part of the team, and it's about your comfort level. It's about you looking at the facts and taking the information from all of these providers and making the best decision for you and your family.
Gotcha. So you have to decide between an IUD and oral birth control. What is the preference? What is your preference as a provider?
IUD all day long. I like the convenience of put it in and forget about it when it comes to an IUD. I do not like having to take or remember to take, or even ask my patients to remember to take a finicky birth control pill, that has to be taken within a certain window every day. I also find that you have more systemic side effects associated with a pill, whereas an IUD is locally acting. The hormone, if it's a hormonal IUD, the hormones that are in that IUD are acting directly on the tissue that it is placed in. And so you don't tend to have sometimes the nausea, vomiting, those more global symptoms you can have with the hormones associated with the birth control pill. Nausea, vomiting, weight fluctuations, sometimes mood fluctuations, skin changes, that type of thing. You tend not to see that with an IUD. And just, my goodness, they're more effective. You put it in and forget about it. Partners don't complain about being irritated. Generally, during intercourse, you don't have to do anything. There's no maintenance. It takes out the user error altogether. I just think it's a beautiful thing.
Okay. And the quote unquote chemical period with birth control pills, is that the same with IUD or no?
No, because birth control pills actually, so what you are doing is mimicking the menstrual cycle. So essentially your hormone levels are here throughout the period. And then you'll notice that your birth control pills have pills on that last row that change color, the placebo, or sugar pills. those are the inactive pills that have no medicine in them. So you're mimicking how your body controls your menstrual cycle. Your hormone levels are here, and then when you take those placebo pills, you withdraw from the hormone. And so you're having a withdrawal bleed. The IUDs, the hormonal IUDs, you get a continuous steady release of medication. So there is no withdrawal period. So sometimes what can happen is it either will significantly reduce the amount of blood loss you have with your cycle because it has thinned that lining of the uterus so much that there's just nothing there to be shed, or you will stop having periods altogether. But there is no period of hormones and then withdrawal, hormones and then withdrawal. That's how your period is generated when you're taking a birth control pill pack for the traditional combination birth control pills.
Okay, and this is just a random question. So like for the birth control pills that people don't have periods, like, I mean, how long can you go without a period? And I guess what I'm trying to figure out is how, like, when do you ever shed your lining? Or is that okay? I mean, I guess menopause, you're not having a cycle, but.
In the situation that you're on birth control pills, it is okay. Because you have to think about what's happening. If you were a woman of menstruating age and you walked in off the street at 25 and you were not having periods on a regular basis, this is a problem. This is not okay. And the reason for that is the tissue inside your uterus, if it does not, if it's not met with the proper hormone regulation and balance, can grow thicker because of the influence of estrogen. And if you allow that tissue to grow continuously unchecked without a natural shedding or release of that tissue, it can become abnormal, precancerous, cancerous tissue. So the body's balance of estrogen and progesterone keeps that cycle in check and prevents that from happening. So estrogen makes the tissue grow, progesterone thins and sheds the lining of the uterus. Birth control pills is hijacking that process. It's taking over control so that it takes over the function of your brain communicating with your ovaries and your uterus. It takes that loop away altogether. So instead of allowing the tissue inside the uterus to grow, that does not happen. And that's the reason why a lot of times you either will have decreased bleeding, blood loss when you're on birth control pills, or you might stop having a period altogether. For example, with the continuous pills where there is no withdrawal period, like the seasonals, those types of pills that cycle you every 3 months. So you're doing the exact opposite. You're actually protecting the uterus by not allowing that tissue lining to grow. So if you think about it, there is no tissue there to be shed, or there is significantly less tissue there to be shed, which is actually protective in that way. So what I tend to say to people is, I like for you to have a period at least 4 times a year, every 3 months. And I find that if you don't do that, you will potentially increase your risk for having what we call breakthrough bleeding, which is just random, unpredictable bleeding as that lining breaks down. Whatever is there can break down. And so I typically say to people every 3 months, but then I want you to have that background and understand why it's not a scary situation, why we don't get worried about you not having a period when you're on birth control pills, because we understand exactly what's going on. It's not an unhealthy, unchecked period of growth for that tissue in the uterus. We are curtailing all of that.
Gotcha. Well, I never even thought about that. So I do have a couple of asking for a friend questions, which, well, I'm not really asking for a friend. But so I saw this meme, and it's like the lady is at the OB's office, and she puts all her clothes on the stool and like covers them up. And it's like, oh yeah, but I'm getting ready to like have my OB like look in my insides, but I'm hiding everywhere. And that kind of brought me to the sense of like when people say, oh, I have to douche because I'm going to go get, you know, my vaginal exam, whatever. What is it okay to douche before you go to the OB appointment?
I don't like douching at all, and most OB-GYNs don't either.
Okay. Well, that's...
Yeah. Now, and this is why. So interestingly, you know, you brought up pelvic inflammatory disease, and actually we talked about pelvic inflammatory disease being infection that starts in the lower genital tract and travels up to the upper genital tract, the uterus, tubes, ovaries. There have been studies that find that women that douche have increased risk for pelvic inflammatory disease because you're essentially putting liquid into your reproductive tract that blows whatever is in the vagina up through the uterus, tubes, ovaries, all connected. So that's one reason we don't like douching. The other is because there is supposed to be a natural amount of bacteria and yeast in your vagina. When you douche or use feminine products, feminine sprays, feminine washes, and some of these other things, potentially vaginal steaming, some of these things get rid of what is supposed to be there. And then when you get out of balance, you can get an overgrowth of yeast, you can get an overgrowth of the bad bacteria, and it causes an infection. And you can get into this cycle of just infection after infection, recurrent infection, and they get increasingly more difficult to treat. And so what we say is the vagina is a self-cleaning organ. It does not need douching. It does not need all of the other kind of external things that we do to it. And when we start manipulating it a lot, we get into trouble because we start disrupting that balance, and that can lead to problems. So, so that's the first thing. And the other thing is, we don't pay attention to that type of stuff. You know, I mean, if people don't bring it to my attention by, you know, oh, I'm sorry, doc, I didn't shave today. It didn't even occur to me. It didn't even register to me in my mind to think about that. You know, I'm just looking at your health and well-being. I'm not looking at the cosmetics. I'm not looking at the superficial. Whatever you choose to do is what you choose to do. And so you know, while it is, you know, your personal space and we all feel, you know, how we feel about it, we have to put that out of our minds because it's not important. I won't remember it 2 seconds after you leave that examination room, and it doesn't even occur to me to be concerned about it. Okay. Yeah. Well, yeah, this whole rhetoric about changing our natural self, it gets me fired up. You know, like we are so bought into just, you know, how God made me is not good enough. I got to change it. I got to modify it. I got to, you know, I just, I hate that.
Well, and I was going to ask you about the wash, the feminine wash, and you answered my question. So I guess just soap and water and
soap and water, mild soap, fragrance-free, dye-free soap and water.
Okay.
Yep.
All right. Well, thank you so much for answering all these questions today. We are going to have part 2 where we're going to talk all about fibroids, but I just want to say I feel like you answered a lot of my questions beyond what I even expected, and I learned a lot. And it's exciting to connect with somebody who is like so passionate about women's health and educating and advocating for patients. So thank you, Dr. Woodus.
I appreciate you having me. This has been great. It was an easy conversation, and I'm just so thankful that you invited me to participate.
Thank you.